Welcome, everyone, to the University of New Mexico Law and Mental Health Series, weekly discussions of practice and science featuring experts in behavioral health and the law. This series is run by the Division of Forensic Behavioral Sciences of our University of New Mexico's Department of Psychiatry and Behavioral Sciences and is supported by the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenters, make sure you enter them in the Q&A box. You can enter those anytime you feel comfortable. Do know that we hold questions until the end, and oftentimes it's not possible for us to get through all of them. If you are pursuing continuing medical education credits, there will be a sign-in sheet posted in the chat box as I complete this sentence right there. So keep an eye on the chat box if you're going to sign in for those credits. If you are pursuing APA continuing education credits, the link for the survey you'll complete for that will also be in that same chat box, but this will be near the top of the hour, near the end of the presentation. So keep your eye on that chat box as we draw to a close. Bookmark or open that link before you leave the webinar so you have that link to complete the survey. When you complete the survey, make sure that you save a copy of your completed survey because we don't have access to the copies of those certificates after the fact. If you missed last week's talk in the series, Dr. Candace Shields' discussion of voluntary and involuntary intoxication, fixed and settled conditions, and legal insanity is now available on our YouTube channel. The recording for this week's talk will also be available on our YouTube channel later this week, and PowerPoint slides for those that have registered in the series will be available for review later this week as well. As a heads up, next week, Dr. Jeff Kukuka is scheduled to discuss exposing and mitigating bias in complex forensic decisions told through the lens of the forensic medical examination of George Floyd. But circling back to this week, I'm honored to introduce you to today's speaker, who'll be discussing American Indian and Alaska Native legal system involvement and access. This is Jennifer Nanez. Jennifer Nanez currently serves as a senior program therapist here at the University of New Mexico in our Division of Community Behavioral Health in the Department of Psychiatry and Behavioral Sciences. Ms. Nanez is an enrolled tribal member of the Pueblo of Acoma, New Mexico, and is a daughter, sister, and auntie. She's also a mother to two young Indigenous matriarchs in training. Ms. Nanez has been in the social work and education fields for over 25 years with experience working across tribal, urban Indian, federal, and university systems, all with an emphasis in serving the American Indian population. Ms. Nanez's interests lie in suicide prevention and mental health treatment support. Her works to promote effective community engagement in clinical practice while emphasizing cultural resilience, connection to traditions, and Indigenous-based knowledge and hearing in American tribes and communities. So Ms. Nanez, Jennifer, on behalf of your home here, University of New Mexico, thank you so much for joining the series. I'm thankful for you sharing your expertise. I know this has been a long time in talking. I'm glad we could make this happen. I'll go ahead and toss it over to you.
All right, thank you, Dr. Perillo. So again, just a brief slide on the CE process. It is in the chat for you all. I do not have any disclosures to disclose. And a reminder that the views expressed in this presentation are those of me, the speaker, and do not necessarily represent the views, policies, and positions of the University of New Mexico. So let's talk a little bit about our learning objectives today and what we're going to cover. So first, we're going to discuss incarceration rates of American Indian and Alaska Natives, analyze risk factors and social determinants of health that contribute to justice system involvement, and analyze tribal systems of justice, accessibility, and challenges, including access to culturally safe forensic mental health evaluations. So lots to cover today, but I'm really, again, happy to be here with you all. You can see my community in my background here. This is the Pueblo of Acoma, where I come from, here in New Mexico. And New Mexico is home to 23 sovereign nations and tribes and pueblos. And I come from one of 19 pueblos here in New Mexico. So I'm really thrilled to join you all and share some information today. So as we're talking about tribal communities, it's really good to remember that while American Indian and Alaska Natives are often lumped into demographic information by race and ethnicity, really what we're doing is we're checking the box at that point, because we're actually considered a political status, and that political status has been affirmed through many separate governments, and especially here in the Southwest through 3 separate governmental systems, first Spain, then Mexico, and now most recently the United States. And so the sovereignty that we have as independent nations within a nation here is really what defines who we are in this political status that we carry. And this particular political status as sovereign nations and this relationship that we've had with the United States does afford access to certain services. But we're going to talk a little bit about those challenges and how they intersect with justice system and how they intersect with, again, mental health and forensic mental health. So I wanted to give you just an overview really quickly of who we are. So in 2020, at least from the census data, and even today, what we have is 574 federally recognized tribes with over 175 different languages that still survive, including my own, the Keres language is what we speak in the Pueblo of Acoma. And as of that 2020 census, we made up nearly 3% of the population. We had a huge growth curve happen between 2010 and 2020. And so we've moved up the ranks in terms of percentage. But when we think about our population, only about 22% of our population resides on reservation, meaning over about 78% of our population resides off reservation in communities like here in Albuquerque, urban centers across the United States, rural communities and townships. So you can find us all over, including throughout the world too. Now, in 2010, just for comparison, we only made up about 1.7% of the population. And why I wanted to introduce both 2020 and 2010 data regarding our census rates is in part because some of the data we're going to see on incarceration is dated both from 2011 and 2019 and beyond. So just thinking about those two data sets as we move forward is really important. So let's get into the data here really quickly. The Prison Policy Initiative is a wonderful site where I pulled some data in particular regarding incarceration rates. And when we think about these in particular, we know that there are definite disparities in correctional facilities and those who are incarcerated. So while Black, Latino, and American Indian populations make up a much smaller percentage of the overall US population, we are definitely overrepresented in incarceration rates. And American Indians in this particular data set at that time frame made up a little over 1% of the US population, but 3% of the incarcerated population. And thank you, I see that chat note. Yes, what about tribes recognized only by a state? Yes, there are many, many state recognized tribes, but that are not currently federally recognized tribes. And many of those tribes are still fighting for that federal recognition. Now, those, unfortunately, we don't see counted in this data that we're going to capture here. But yes, I want to speak to the fact that there are many state-related tribes out there that we don't necessarily see data captures for. And that's a challenge because we know then we see that disparity potentially increase even more so if those were counted in these data points here. Now, just to note that when we think about state representation, and we're talking about that just a bit here, although we're still talking about federally recognized tribes, we still see overrepresentation of our population in state jails and in local jails in communities. So the following states, North Dakota, South Dakota, Montana, Wyoming, Utah, and Alaska, are definitely states where we see major examples of overrepresentation of American Indian populations. Now, while those states do have higher American Indian population rates, we know that they're still overrepresented in the overall correctional facilities there. One of the more egregious state examples is in Alaska, with American Indian and Alaska Natives making up only 14% of the population, but 40% of the incarcerated population there locally. Now, one of the issues and challenges in data is also the way that we're counted. And if we examine only individuals who identify as only singularly non-Hispanic American Indians incarcerated in local jails, we see that those numbers seem fairly low, about 12,000 individuals across local jails. Again, these are not state facilities, these are not federal facilities. These are most likely municipalities, townships, urban centers with their local jail populations. That number seems fairly low. But when we increase that with identification of either Hispanic American Indians or those who include an additional race, that number jumps up. Now, local jail populations, when we look at 2019 data, what we see over this course of time from 2000 to all the way to 2019, the local jail population for American Indian and Alaska Natives increased by 85%. Huge jump there in terms of the incarceration rates. And this is again really concerning when we look at the overrepresentation happening. Now, these particular counts, when we talk about that 85%, does not necessarily include tribal jails. Now, our own tribal communities do, in large part, have their own tribal justice systems and jail systems available, but these don't necessarily get counted in overall local jail data as well. So that's something that we need to consider. Now, what you see is what we call Indian country, and that's areas where we see large American Indian populations across the US in areas and states that have tribal populations and tribal jurisdictions. So we have both local jails and then Indian country jails and then tribal jails to consider. Now, more often than not, too, we're often involved in both state and federal prison rates too. And so Native people are incarcerated in state and federal prison rates at a rate of 763 per 100,000 people. And this is actually double the national rate, 350 per 100,000 for non-Hispanic whites. And so when we think about this again, that overrepresentation, we're such a small population still within the US, even though we've had this big jump in numbers from 2010 to 2020, we still see that we're overrepresented in the incarcerated population. So we're going to segue here just for a moment to talk about social determinants of health, because what we often see is incarceration is tied to lack of access or challenges within the social determinants of health. And that's same and true for health overall. So we first need to start out with our lovely friend and colleague, Dr. Maria Yellowhorse Braveheart, who worked with us here within our department and division and just retired last year in July of 2024. And Dr. Braveheart's work has really been, again, the primary work that's helped give language to what our communities have experienced over time. And this is this discussion around historical trauma and how historical trauma can again set up these challenges within these social determinants of health and how they've influenced those over the course of time. So she talks about historical trauma as the psychological and cumulative emotional wounding over the lifespan across generations emanating from massive group trauma. And for our American Indian population in particular, we know that's been a challenge for us. It's been part of this colonization process over these last 500 years. When we also think about, again, this critique at times of historical trauma is in part because most folks tend to think about this as in the past. But in truth, we know that this continues even through present day. And Dr. Braveheart consistently has noted that her model of historical trauma is not just based in history, but even in the present day. But McKinley and colleagues in talking about historical trauma note that they feel it doesn't necessarily fully explain that pervasive and chronic oppression that we face. And so they developed a theory called historical oppression. And that space is this chronic, pervasive, intergenerational experience of oppression over time that may be normalized and imposed. And so one thing to consider is that oftentimes policy and law is what creates these impositions that create challenges around these social determinants of health, access issues, all of the challenges that we face. So when we think about this in particular, this is where we begin to look at this combination of both trauma histories, as well as oppression and social determinants of health and how they begin to intersect. So let's talk for a moment about trauma for an example, just to take a look at this, both trauma and adversity. So trauma and adversity are experiences that are proven to contribute to this risk for risky behaviors and justice system involvement. And while the overall US population has at least one ACE, 97% of the prison population has at least one ACE, and 78% of the incarcerated population report 4 or more ACEs. Now, we know that in those adverse childhood experiences, there is that potential to again increase that risk over time throughout the lifespan of risky behaviors, negative health consequences, and that potential for early death. We also know that it can be a contributing factor for justice system involvement. And as we tie this back to Dr. Maria Braveheart's work, as well as again those talking about historical oppression, we have to examine colonization as trauma. And our populations have been subjected to this systemic, targeted, race-based trauma. And these trauma histories are extensive in nature, and they've lasted centuries. And we have so many examples here in the US alone, including for our African American relatives, and of course, for our communities, the American Indian population and Alaska Native population. So we have to consider that, because we might be thinking about individual traumas as we're working with our clients, with our community members coming in, with our relatives coming in. But we also have to examine this within the context of the population and that potential for population trauma overall. So how do we start seeing this impact our communities? We might see it through education access. We might see it through housing access. We might see it through economic challenges, health disparities beginning to present themselves. So for example, here again, from some wonderful data from the Prison Policy Initiative, you can see again access issues around education and completion rates. And for our American Indian population, you see that 58% of those who are involved in state prison systems around that time of 2016 or so, 58% had completed less than high school education. Some had completed some high school, and then some college or college degrees. But this again has a role to play in those educational systems. And what are those educational systems like? Have they been supportive? Are they discriminatory potentially in nature? Have they been difficult to move through? One of the more recent webinars that we gave around American Indian suicide related data is that we found locally here in New Mexico that discrimination felt in school systems is one of the highest contributing factors to suicide risk for our youth. So educational systems again play a key role for our youth, and of course, as those youth age into adults as well in adulthood. Now, we've mentioned housing, and again, housing can be a challenge in many of our communities across the nation, especially on tribal reservations, do face housing challenges. As we extend out into urban communities, into our townships, and again, rural communities, housing still can be a challenge for our people. So when we see this information, again, living space in the 30 days before arrest, you see some of those challenges that our population faces. Maybe residing in someone else's house or apartment prior to being arrested, living in a rooming house, hotel or motel, or being homeless and again, sheltered or in the streets at that point in time. So what we see is that that can be a contributing factor. And again, looking at this homeless in the year prior to arrest, we have one of the highest rates, unfortunately, of being unsheltered in that year prior to an arrest occurring. So that can be a factor, again, contributing to the likelihood of justice system involvement. Again, youth are overrepresented as well, in our American Indian youth in particular, seeing their first arrest happening at age 18 or younger. And what we see in comparison to the non-Hispanic white population is that that's, again, 70% as compared to 59%. And our males, again, are again being incarcerated at younger ages than our female populations. So let's take a look a little bit more specifically at these social determinants of health for our communities. Take, for instance, again, housing. 88% of tribal housing officials reported homelessness was a problem in their community. And this does not mention the number of people, again, staying in overcrowded conditions. Having worked within my own community in the past, we were aware of overcrowding within homes, in part because of the lack of homes. Now, while we talk about multi-generational homes being very common in our communities and being very supportive as well, overcrowding can still be an issue and still be challenging. So this is something that we're still working with within our populations. Digital access, and again, this is related to healthcare and education. In 2020, 34% of our households had no high-speed internet access or home, and nearly 1 in 5, again, without a computer. And so this is also challenging when you're trying to, again, access resources, engage in healthcare, engage in education for our communities and our youth. And again, even just getting resources and information into the home. Educational attainment, like we mentioned, can be challenging. And we have one of the rates, again, of highest American Indian populations who did not complete K through 12 education. And so we talked a bit about how educational systems can be supportive or unsupportive, and that can be challenging in, again, completing education rates. A few others just really quickly related to economics. The median Native household income is around $37,000 compared to $53,000 for the nation as a whole. We have, again, big gaps in insurance coverage when it comes to healthcare. And again, that dropout rate for our population is still pretty high. Now, roughly a third of our population still lives in poverty. And this is, again, not just unique to, again, our population on reservation, but even those off reservation. And even when we adjust for that, those rates still remain low, unfortunately, in economic attainment. And of course, health disparities. All of these challenges that we face begin to present themselves through our bodies, through, again, issues like diabetes, heart disease, again, hypertension, and mental health rates that we see within our communities. Now, as we've been talking about these disparity rates, again, it's important to note that this is not because of who we are or our value systems or the way we care for each other. In fact, Indigenous values and the way that we live and breathe and operate within our communities are based around holistic overall health and wellness. The challenge that we face are these impositions of systems that we have to navigate through and gain access to housing, gain access to economic development, gain access to healthcare, gain access to mental health services. And we're going to see a little bit of that here next. So service access is definitely a challenge, and American Indian populations have to jump through so many more hoops than your everyday person out there, no matter what race or ethnicity, in part because we're navigating systems at the federal level because of our relationship as nation to nations, and at the state level because we are state citizens. Again, we're citizens 3 times over, and we might be navigating that within our own tribal communities, as well as those private systems that exist in these spaces in states and in the nation overall. So the primary provider for us for healthcare is the Indian Health Service, and it's the federal entity that's responsible for, again, the healthcare of all American Indians. However, there are so many issues around eligibility that really begin to restrict access to that service. And what we see is that those eligibility requirements really reduce down access for our American Indian population to those services, and they're often not available outside in communities where our populations reside. And IHS is not an insurance program. I want to say that and emphasize that, because the myth is that, do we receive free healthcare? Yes and no. If we can get it through the Indian Health Service system within their facilities or within what we call Tribal 638 programs in our tribal communities, yes, we don't have a payment for that service. But oftentimes that particular service, again, is limited in nature, not only in terms of access, but also what it offers. And so that can be challenging. especially when we begin to think about access for mental health treatment support, and even more so forensic mental health. So IHS is not an insurance program. It doesn't travel with us. It doesn't go to other facilities. It doesn't pay for services necessarily in other avenues. And it's limited in part with these access and eligibility issues to really only 1 in 5 American Indians. And this is challenging because, again, it's impacting our care. Now, does the Indian Health Service provide forensic mental health support? Yes and no. This is the policy piece taking directly from the Indian Health Service manual. And just to know, I'm a former Indian Health Service employee, so full disclosure, I've served as an acting behavioral health consultant in the past and oversaw grant funding within IHS. But forensic services is a very specialized field, as you all know, and this is why we're here today speaking with you as experts in this field, but trying to tie this again back into our population and population needs. Now, forensic services has been offered through the Indian Health Service, but in more recent years, there was an unwritten rule that forensic mental health services were not available through IHS. One, in part because of staffing, two, in part because of other challenges that the Indian Health Service system overall will put forward and say, this is where we can't provide this in this context. But what's challenging even more so is when it happened, or when it was provided, or when there was a need for testimony from providers working with patients and clients who were going through the justice system, is that federal rules govern how that information is provided and when testimony can occur, something called the TUI rule. And again, these requests have to go into those regional offices and directors and managers of these programs for approval, and often take 30 days for that approval process to occur. Not to mention, they may say, wait, we need more information. Wait, we need to again review records before that approval can happen. And we know that creates challenges on the justice system side for, again, that fair access to, again, support and throughout their criminal trial or their trial period. Now, the other thing that defines access to and where justice systems intersect with our population is also related to this, what we call the Major Crimes Act. And this particular Crimes Act is what sets jurisdiction on where our populations engage in service. And if a crime is to occur within reservation boundaries, or what we, again, in this instance, call Indian country, there are many, again, rules of law that define that. And this is the overarching one. Now, when was this law passed? You might ask. The Major Crimes Act. It includes things like murder, manslaughter, kidnapping, sexual abuse, intimate partner violence, assault of a spouse, dating partner violence, all of those things that we're familiar with. But this law, believe it or not, originated in 1885. And we're still bound by this law in our tribal communities on how crimes are prosecuted, where crimes are prosecuted, and again, what sentencing requirements are bound for our populations. And so this is just a brief look at, again, jurisdictional charts just for our population, depending on who was the offender, who is the victim, and where did this crime occur. And so this is also challenging in navigating these systems, not to mention if we're having to navigate systems on the state side, the local side, all of these come into play for our population. So what does this mean for us? Well, in terms of prosecutions and outcomes, it does vary depending on the jurisdiction. And unfortunately, in many cases, American Indian and Alaska Native offenders may face significantly longer sentences for the same crime that may be perpetrated by a non-Indian, because it's based on the location of the crime and the victim of the crime. And again, very challenging for us. So when all of this intersects too, is what we're not seeing at this moment is, where does forensic health and mental health come into play? And how are we, again, evaluating these populations who are coming into these justice services? What are these mitigating factors these social determinants of health, these environmental things that may have contributed to this risk for involvement. Potential health issues, traumatic brain injury, for example, where does that come into play? All of these navigation systems are difficult in and of itself, not to mention when we have these additional challenges around mental health risks that come into this process. So let's talk a little bit about the role of providers in mental health and forensic mental health, and what we're hoping to convey here in our conversation today. So when we think about providers overall, healthcare providers within these systems and creating these relationships with our communities, we know that no matter who's coming into the room with us, we're bringing with us as a patient all of these histories, these experiences. And for our American Indian populations, we're often bringing in these histories of betrayal from these systems, these histories of issues with access with our systems. That's all coming into the room. And unfortunately, what we know is that our providers often aren't educated around these issues and challenges for specific populations that they may be encountering, like American Indians. And we're in that space often of hoping that we're coming into a space where we're not seeing bias, we're not experiencing that in that room with you. But oftentimes we might have that vulnerability there as a provider to intentional or unintentional bias. And it leads to this paradox of a well-intentioned provider or physician potentially providing inequitable care. And so this is the challenge that we face as providers in the system, as you all working within populations across the United States and with our populations in particular. So just a note, because when we think about equitable care, equitable care can be what we're striving for, but it can be compromised by poor communication, lack of partnership with that person who we're providing that service to. Are we including them fully, or are we creating power differentials with knowledge, with education? Yes, that's definitely present, but what are we doing to make sure we're being in partnership with that individual in that space and considering all of these factors as well? And what we know is that inequalities are primarily due to these unequal power relationships, unfair distribution of social determinants of health, like we've talked about, marginalization, bias, unexamined privilege, and even institutional racism, or what we call structural violence. These systems that are so difficult to navigate that don't fit the population served. But culture also plays a role. And when we think about coming into this space for accessing services, what we're seeing is that all of these cultures collide. The client's culture and history and background and population history and background and experience, the clinician, you as the clinician coming in, and this culture of medicine, this culture of these systems. And so this is where we begin to see all of these clashes potentially happen. Now, forensic mental health has been starting to pay attention to this, but only unfortunately very recently so. So Bergkamp writes in 2023 in regards to research in forensic psychologists that for research in this field seldom address cultural considerations, especially when thinking about pre-trial evaluations. And it's really only occurred in this last decade or so. And there appears to be this growing consensus that cultural responsiveness should be included when we're looking at that forensic psychology toolbox. But what was interesting most about this piece was that they encourage practitioners to utilize existing methods and tools. We're going to talk about that here in just a moment, and integrate cultural factors into that. Now, we've all been subject to adaptation, and that word adaptation in evidence-based practice models, and it does not always fit, because what we know is that these tools have not necessarily been developed with our participation. They have not been normed in our communities. They have not taken into account our histories and our experiences, nor necessarily our way of response. And again, that can come up in this interpretation approach when we're looking at existing tools and methods out there. So again, regarding this, Shepard and Willis Escada wrote on Indigenous perspectives on violent risk assessments. They note that there's this paucity of minority representation in validation samples. And even when we look at the models of actuarial versus structured professional judgment models, both remain at risk for bias, not just psychometric, but potentially personal, education, and training bias. That can come into play when we're utilizing these existing methods and tools. We need to examine those and look at what works from an Indigenous perspective, especially when we're thinking about these issues and disparity. Are these tools potentially contributing to these disparities as well? That's a challenge. And so one of the examples that was given by Willis and Escada and Shepard was this review of structured assessment of violence risk in youth, the SAVERY tool. And they had a number of American Indian and First Nations professionals, both here in the US and in Canada, looking at this particular tool and critiquing this particular tool. And these included, again, even the Society for Indian Psychologists reviewing these tool sets. And what they were finding is that wording in it of itself of the tool could be very biased in nature in how it elicited responses. Again, school performance being one of those primary areas, being bullied or disliked. But when we talk about our school systems, not to mention both, especially off reservation, we often find racism and discrimination playing a large role in that. And so while we might have a youth who has poor school performance and that being considered a risk factor, or again, that disengagement from school, not inability, but dislike of school being a risk factor, it may not be the individual that themselves, it may be the school system that contributes to that. And where are those supports potentially? But these do not necessarily capture that in these tools and in assessments. The other piece too is like, what defines family? For our communities, you hear us talk about our relatives, our families, and oftentimes that is way more than the nuclear family, the mother, father, and children. We're thinking about grandparents, aunts, uncles, clanship relatives that we have. And that's our concept of family. And so oftentimes these tools are very small and focused, but these relationships, these relationships even beyond our nuclear family, are incredibly important and incredibly supportive as well too. But oftentimes we're not asking about that in these broader systems. So we need to take a look at that, like who's defining these for us? What does it mean to be financially secure? Who defines that? Who defines family, and how do these assessment tools necessarily define family? What are formative experiences that you might be asking or a tool might be asking? But do you know what our formative experiences are? Those cultural, traditional, or culturally religious ways definitely differ from Western or European constructs, and that's really important for us to consider. So this is really challenging, and our hope is that over time, as we're building our workforce from our communities, that our people, again, serving in these roles of assessment and service provision, understand that, are taking that into consideration, are, again, critically thinking about the tools and the methods that they use. However, what we do know is, unfortunately, we have, again, underrepresentation in these positions, like in forensic mental health and really mental health overall. So right now, in terms of the data, what we're aware of is only about 10% of all psychiatrists are either African American, Hispanic, or American Indian. And I imagine that the American Indian rate there is incredibly small. And even for psychologists, Dr. Gahn in 2018 noted that he was aware of only about 260 American Indian and Alaska Natives psychologists nationwide. So that's a small, small number when you think about what did we say? Almost 9 million people, 3% of the population. And again, 574 different tribal communities federally recognized, not to mention our state relatives as well. And so that's incredibly important when we think about these disparities and how we're being assessed, how we're being viewed, how service provision is being provided, and is this culturally safe care? Now, the field across time, including my own of social work, has tried to address this. How do we again ensure that we're paying attention to this? And we've seen that progression over time. Cultural awareness, we worked on sensitivity for a time. Cultural competence was the big buzzword for a long time in all of our fields, trying to be competent in cultural considerations. Where we're at now is the space of cultural humility, and you hear that quite a bit. But this is this one-on-one relationship that we're working to build, this lifetime learning, this connection that we're doing with our client that is in the room with us. But cultural safety, what we're arguing for is this examination of more of these systems approaches and challenges that we're talking about here. So cultural safety really is taking a look at how do we decolonize care? And that's a term you've heard often used in these last couple of years, especially from Indigenous populations. But it's in part because the systems that serve us have been created under this construct of colonization overall. Now, while culturally competent practices and where we stayed with competence for some time and even cultural humility can improve care, it doesn't decolonize care. It doesn't move it into this space where it's safe for us still. And so this term cultural safety and this framework of cultural safety is what we're striving for and what we're promoting, especially within our systems of care locally and now more so nationally. But globally, this particular framework has taken root in where it originated in New Zealand and in Australia, in India, in England, in Canada. It's still new within the US. And there's a lot of, again, pieces around colonization and oppression that relate to that and the reason why it hasn't picked up. But you see it being utilized in many other countries with these histories of colonization of Indigenous or Aboriginal or First Nations populations. So our goal is really to look at systems and how that can impact care and how we're thinking about this overall, these access issues, these challenges. And what defines safety is those who receive the care, not us creating a system that says, this looks like this should be safe for everyone, or this is how we as a system define safety. What we're needing in cultural safety is for the population and the individuals to define what that means for them. So we're looking at these systems and how they can impact care. Now, in forensic mental health, Shepard and Luis Fernandez, and Luis Fernandez is a colleague of Dr. Maria Yellowhorse Braveheart, they write that notions of cultural competence and safety are not explicitly embodied in these standardized risk assessment frameworks. And so those existing tools or models that you might be using within your work do not incorporate that. And that's a challenge. And the capacity for a minority individual to receive an accurate risk adjudication or have their specific needs identified is potentially diminished. And what is more concerning is it violates notions of cultural safety and international human rights, our human right to have an accurate assessment, an accurate portrayal of all of these things that come into play that may contribute to justice system involvement. And a little bit further here is that when we think about Indigenous populations in particular, and again, considering forensic mental health services, that there's barriers to that implementation of culturally safe services in these contexts where the liberty of the service user, the person that may be just as involved and who may be, again, in a state of incarceration or being held potentially, is constrained by these non-Indigenous institutional controls, and that we're intersecting with these systems that were created in these processes that can be discriminatory, that can contribute to this overrepresentation. that is engaging us at higher rates than any other population or non-Hispanic white population, yet we're still such a small number. And so this is really, again, challenging and can revive important intergenerational and historical trauma. So we need to examine this cultural safety and forensic mental health, because if we don't, especially for Indigenous populations, it really again looks like this imposition of dominant cultural values on our population and not necessarily Indigenous values. So we need to begin this work towards creating culturally safe care. And those individuals that are coming to you in these moments for, again, evaluation, at risk potentially for incarceration, having had maybe histories of individual trauma, having had histories of communal trauma, having had histories of population trauma, they're coming at very vulnerable times. And so these perceptions of, again, bias potential, power differentials, if we're not attending to them, these histories of systems and the way they're created, these challenges in accessing care can all create for unjust systems, including the ones that the ones within which we work. And this is the challenge for us as providers to consider and also, again, face. How can we change systems? How do we really evaluate and critically think about the tools and the methods that we utilize? How are we, again, encountering this person coming in and taking into impact all of their history that they're bringing with them? But when we create culturally safe care, even in these spaces of forensic mental health, even in these spaces of at risk for incarceration, even in these spaces where a crime has occurred, and we're trying to, again, address that and provide justice, culturally safe care can create, again, ripples of impact for generations and how that's approached within our communities. Now, in this space here, we've been primarily talking about defendants coming into justice services. But evaluation and forensic mental health is not just limited to those. It might be limited to those on the other side as well, on the prosecution side, individuals who have been victimized and are looking for justice. And those same issues apply even on that side as well, too, for our populations. So all of this is a challenge that I'm putting out to you all to think about critically the field that you work within, the methods and the tools that you utilize, and again, these histories of populations that may have this overrepresentation in our systems, and think about those reasons why that has happened, and what are those systems and those access issues and histories that have contributed to that. So again, I want to thank you all. This is a huge, broad topic. I'm definitely not the primary expert in this, but I wanted to bring this forward in part because culturally safe care in all of these avenues is incredibly important, not just for our Indigenous populations, but really for everyone overall. And the reason why we have to consider this is because when we do design systems to address these needs of populations who are at the highest risk, the highest disparity, then don't those systems benefit everyone? Those are the systems that take care of everyone and provide that safety and that care that's needed. And our hope is that we can do that, not just for populations at high risk, not just for populations with the highest disparities, but for everyone. And so my hope is that this has given you some food for thought. There's some wonderful references and resources here for you all to take a look at. I've included those for you. You can find the links for many of those here that are active that you can reach directly from the link here. And I hope that this has been, again, a good discussion, good topic item for you all, and food for thought for future engagement with our populations.
Yes.
Dr. Patillo?
Yes, and thank you so much, Jennifer, Ms. Nanez, for all of this wealth of information, as well as your careful, compassionate, holistic approach to all of these issues. It's much appreciated. We do have a number of questions in the Q&A box already. I'll go ahead and throw some of those to you. In the meantime, if anybody has additional questions for Ms. Nanez, you can enter them in the Q&A box anytime you feel comfortable. The CEU survey should be in there fairly soon. In the meantime, if you could advance one more slide, I believe there'll be a QR code there. There, and there's the QR code there for anybody to scan. Thank you for that. And the link has now been posted in the chat box as well for the APA CEU surveys. We're getting a number of different thank yous for an informative, thought-provoking presentation, this being inspiring, finding it highly salient to my practice, and a topic that's seldom addressed right now. So it does seem like this was particularly well received by many people. Somebody asked, do you think that the focus on adaptation is due to the lack of appropriate assessments and interventions now? How do you think we can practice in this space competently and safe culturally while we wait for the science to develop?
That's a wonderful question. And having been a part of adaptations over time with evidence-based practice models, every time we've been through those iterations, our end discussion has always been, we need to create them for ourselves, for our own community. And that is the challenge. I think when you begin to really dig into those assessment tools, interventions, we have to think critically about who was this developed for, where was it normed for, what's the prevailing determination on who's defining family, who's defining any of those items that we're beginning to try and evaluate. And more often than not, of course, they're not based in Indigenous communities. And so this is challenging. And then while we wait, we have to again turn to our communities to say, how can we have our communities, our professionals that are within the field, really examine those and critically help us think about those. That one article, especially on the Savory tool and that evaluation of the tool from an Indigenous perspective and from Indigenous professionals, psychologists and psychiatrists, really broke it down. And I really enjoy reading that in part because this is what we need to do when we're thinking about these tools. And if you need someone to help you with that from our communities, please reach out, because I think oftentimes coming from a space of education and training and not having exposure to these communities, we might think that these tools are great, but in truth, we might be noticing that bias if you spread them out and have folks really look at them critically. So thank you for that question. And again, coming from as an Indigenous person in Indigenous perspective and having worked through adaptations, we always come back to this. We have to build them for ourselves because this is not meeting the need and it can be potentially biasing in how we're being seen. Mm-hmm.
Sure. And as an aside, maybe a mental note for me when we communicate later and all that too. I know at least one of the authors from the Savory articles that you've discussed has discussed additional interest of discussing whether in this series or with UNM and all that some of the work they've done with Indigenous populations. So I'd be happy to put you in contact with them too, if anything.
Wonderful.
Yes. Somebody asked if you're aware of any research linking generational trauma to negative epigenetic genetic impacts on mental and behavioral health.
Well, we definitely, again, are aware of that, in part because these histories of trauma, as we know, does create epigenetic change. And we have seen higher rates, again, of mental health challenges, of substance abuse use, of, again, health disparities that contribute to potentially mental health challenges. So they're definitely connected. But one thing I want to say, again, thinking about our communities is while we have all these challenges, and we've talked a lot about the data here, the fact that our populations, after 500 years plus of all of this subjugation, of colonization, of these traumas and tragedies, are still here and are still very, very vibrant. Especially here in New Mexico, you know, the Pueblos in particular, and of course, the Navajo Nation, our Apache relatives, are all still thriving, you know, with language, with culture and traditions. And those are the most protective things that we have. And one of the challenges that does come up is that only recently, in the last 5 decades or so, really have we been allowed to openly practice that. in our communities because of federal laws at times. So religious protections that we have came about again as federal law. Pueblos in particular have been underground for so long in terms of their traditions and language that this is why it's still very vibrant in our communities. But unfortunately, we see our relatives in other states who have been highly impacted by that. Now, it's not to say that these challenges, again, we're not working on, we are. And this is again for our communities where the healing is coming internally and bringing forward our resilience through our culture, through our tradition, as ways of treatment approaches, as ways of prevention. And we're beginning to really see that tide shift now. And that's what's really neat to see. One of the more recent pieces here in New Mexico is we saw a huge drop in suicide, 43% in the 2021 to 2022. Big drop. And we have to really think about how we're hoping it's a trend, but it's in part because our communities are working more towards that, are finding ways to incorporate culture and tradition into those approaches. And that's what's protective, not just evidence-based practice, but really it's our own what we call practice-based evidence, things we have been doing for centuries, millennia, that are important and are healing for our communities.
Wonderful. And thank you for that framing there at the end of practice-based evidence there, to recenter what a lot of this conversation is about. Somebody asked about community health center, medical legal partnerships, saying they seem promising, but do any of them offer substantial assistance to Native communities?
That's a challenge, and in part because many of these are not necessarily centered near our Indigenous populations on reservation, for example. And for those that are addressing our urban Indigenous population, they can be limited. And even those urban Indian centers that are those community centers are still funded through the Indian Health Service. And the Indian Health Service has been funded at less than 60% of need. We're about to get cut apparently again. And if that happens, then you start seeing that trickle down to those community clinics that generally serve our populations. The challenge with engaging broader systems of community health-based services is they're not necessarily always culturally competent. I hate to use that word, but culturally competent in working with Indigenous populations. And that can be challenging again. So why we often are looking to services that are created for us by us is why we're engaging, because we know that they're going to speak to our needs. Unfortunately, they're just not always available, especially once we step out of our tribal communities. And so that can be challenging. It is promising, but there's those training needs, that education, again, thinking about culturally safe systems and how those are developed before we really begin to engage in those. Our hope is that we can.
Certainly. One final question here as we wrap up. We often, when discussing differences in incarceration rates and crime statistics for different minoritized or oppressed populations, we often get questions about how much of this is disparate focus versus actual elevated levels of crime. And so one question here is, with the particular context of I'm from South Dakota, surrounded by reservations, aware of the crime rates among Native populations compared to the overall population, it's high. Is the Native American prison population consistent with a higher crime rate among Native Americans?
Nope, it's definitely disparate treatment and a disparate prosecution. And again, disparate lack of access to defense. And again, those service needs that we have. And so, no, we do not have higher crime rates. Unfortunately, we are subjected to higher incarceration rates. And so we see folks that, again, may not have committed crime, but are often swept up in the justice system just because of our population's identification and that racism and discrimination in our systems. So this is really challenging still. We do not have higher crime rates than any other population. In fact, it's my understanding that the non-Hispanic white population has the highest crime rates by any race or ethnicity, yet their incarceration and prosecution rates are incredibly low.
Ms. Nanez, Jennifer, thank you so much for sharing all of this information, for the work that you do in this area, for the outreach that you do, for our communities. And yes, and as a professional, personal side, it is a pleasure to be in the same little group with you, working together. So thank you so much for sharing all of this info with me and with everybody else here in the Law and Mental Health series. It's been a pleasure.
Thank you. Thank you, Dr. Perillo. Thank you, Alex, too, for all your support. And thank you, everybody. If you would like to reach out to me, you can reach me through Dr. Perillo. He knows how to get a hold of me. If there's questions you still have, please feel free to forward those on. I'd be more than happy to address them. Thank you.
Absolutely. And that wraps up this week's Law and Mental Health series. Next week, we're scheduled to have Dr. Jeff Kukuka discussing bias in complex forensic decisions told through the lens of the forensic medical examination of George Floyd. We hope to see you then for another great discussion of issues in behavioral health and the law. Until next time, take care.